Hi, everyone. I'm Dr. Susan Williams. I'm an internal medicine doctor here at Valley View Hospital. Welcome to Valley View University, the Women's Health Series. I want to thank you for coming today. And before we get started, there's just a few housekeeping items to take care of. Just to let you know, you can submit questions through the Q&A chat on the bottom of your screen, and your question could be answered live at the end of the presentation. We'll try our best to get to all the questions. But note, we're unable to answer questions regarding personal health information. Okay, okay, great. So my presentation today is on living well as you or we age, practical tips for lifelong vitality. This is a pretty broad topic. So as we go along, I'll tell you how I decided to narrow it down a little bit. A quick disclaimer, this content is only for informational purposes and should not be used in place of an actual doctor's visit. Here's an outline of what we'll discuss. We'll start with vitality and what it means to me and to you. And then I chose to narrow this down based on the main disease processes that affect us as we age. And those would be metabolic dysfunction, atherosclerotic cardiovascular disease, otherwise known as heart disease, cancer, and Alzheimer's. And then after talking through those topics, we'll talk about some other screenings to round things out. And we'll also talk about screenings we don't typically do because I anticipate there'll be some questions about those. You start with a quote from one of my favorite authors, Maya Angelou, says, "My mission in life is not merely to survive, but to thrive." And I think that another way to think of that is that there's lifespan and then there's health span, and they don't equal each other. Lifespan can be thought of as how long we live, and health span is how well we live. Vitality comes from the Latin vitalitas, which means life force. It's the capacity to live, grow, develop, or exhibit strong energy and health. So it's more than just longevity, it's energy and function and purpose at every stage of life. Okay, so to talk about the main topics, the major cause of illness and death, we're going to go through metabolic dysfunction and heart disease, cancer in general. And then for neurodegenerative diseases, we'll talk about Alzheimer's more specifically. What is metabolism? It's the process by which we take in nutrients and break them down for use in the body. So in someone who's metabolically healthy, those nutrients are processed and sent to their proper destinations. And somebody who's not metabolically healthy or is unhealthy, many of the calories they consume end up where they're not needed or can actually do harm. You may have heard of the term metabolic syndrome. These are the 5 criteria for it. The first is high blood pressure, and that's a blood pressure greater than 130/85. Or if you have high triglycerides on your cholesterol panel, greater than 150. Or low HDL, which is sometimes considered the good cholesterol on the cholesterol panel, if that's less than 50. And then central adiposity, which for women is a waist circumference greater than 35 inches, or an elevated fasting glucose. If you meet 3 of these criteria, then you can be considered to have metabolic syndrome. By the way, obesity and metabolic syndrome aren't the same thing. Nearly 10 million Americans are normal weight but metabolically unhealthy. And conversely, you can have obese people who are metabolically healthy. But visceral fat is this central adiposity we're talking about. A lot of that is visceral fat. And that's fat that are around your internal organs, like your liver and your pancreas and your intestines. And it's biologically active. It's not just storage fat like subcutaneous fat is. So it drives disease through liver dysfunction, chronic low-grade inflammation, and insulin resistance. and it also can increase heart disease risk. So basically, this visceral fat around the organs behaves like a hormone factory that pushes the body towards diabetes and heart disease and fatty liver. Visceral fat also alters estrogen metabolism and cortisol signaling and leptin resistance, and that explains in part why menopause accelerates heart and metabolism-related risk even without having major weight gain. Poor sleep through similar hormone changes, increased cortisol and decreased leptin, leads to visceral fat. So when you're getting bad sleep, it's basically telling your body to store fat. Visceral fat can be thought of as one of our first warning signs, and then that fat drains straight to the liver, which can lead to fatty liver. We used to call it NAFLD, or non-alcoholic fatty liver disease. Now we call it MASLD, metabolic dysfunction associated steatotic liver disease. And this basically just describes fatty liver disease driven by metabolic risk rather than alcohol or other liver insults. And once the liver is insulin resistant, then fat spills into our muscle. So this is healthy muscle on the left side of the screen, and then you have fatty infiltration, and finally that leads to insulin resistance. So as visceral and even subcutaneous fat expand, it accumulates inside the muscle. And muscle is not designed for fat storage, so it blocks insulin signal so that glucose or blood sugar can't enter the cell, even when the insulin levels get really high. And healthy muscle is the body's biggest insulin organ, and when you get fat inside the muscle, it turns it off. So this intramuscular fat can explain why some women might say, I exercise, but my blood sugar keeps getting worse, or I've lost strength and energy, I feel inflamed and stiff. It's because the muscle itself is sick. But we have powerful interventions, and the most powerful one is resistance training. So resistance training, and this is a theme that we'll hit upon a few times in this presentation, but it reduces intramuscular fat, it restores insulin signaling, it improves mitochondrial density. Mitochondria can be thought of as the powerhouses of the cell, and it improves energy even before weight loss occurs. So insulin resistance is also associated with the other diseases that we're going to be talking about. So having insulin resistance increases your risk of cardiovascular disease almost 6 times, risk of cancer up to 12 times, and can increase one's risk of Alzheimer's up to possibly 5 times. But there are ways to improve insulin sensitivity, and this is at any age. And again, one of the first and foremost things to do, for the reasons we just discussed, is to build and protect muscle. Another thing is to move after meals, even 10 to 20 minutes after a meal, specifically after dinner, dramatically lowers those post-meal glucose spikes. Prioritizing protein. So we want to aim for 25 to 30 grams of protein per meal. I know a lot of us don't get as much protein as we should, so really trying to hit that 30 gram per meal protein threshold is what we should be aiming for. And this helps preserve muscle, and it reduces insulin spikes and also reduces cravings. And before worrying about having the perfect diet, we want to make sure we're getting 7 to 8 hours of good sleep per night. And this may mean that we need to treat hot flashes or insomnia or sleep apnea, all of which you can talk to your primary care doctor about. And I know Dr. Hoffman is going to be having a talk on menopause coming up, I think on the 18th. So we can also reduce late night eating because a longer overnight fasting window improves insulin sensitivity, and then lower cortisol. So stress equals glucose release. So we want to favor calm metabolism, like things like breathing, walking, strength training over cardio overdrive. And remember that small changes done consistently beat making extreme plans. So as far as heart disease goes, it's the leading cause of death in the United States. About 2,300 people die every day in the US of heart disease, and American women are up to 10 times more likely to die from ASCVD or heart disease than from breast cancer. And atherosclerosis begins with metabolic injury long before we first experience chest pain. So how does this insulin resistance and this metabolic dysfunction become heart disease? Well, insulin resistance injures blood vessels. So heart disease in women doesn't usually start with blocked arteries. It starts with insulin resistance. And then the downstream effects of fatty liver, visceral fat, and fat inside the muscles quietly injure the blood vessels for years. It creates a more dangerous cholesterol pattern. So by the time the cholesterol looks, quote unquote bad, process has often been going on for a long time. MASLD, or the metabolic associated liver disease, amplifies ASCVD risk. Chronic inflammation damages the lining of the blood vessels. Stiffer arteries form from that, and then plaques form earlier and can rupture more easily. All right, and then as we talked about, intramuscular fat worsens this whole cycle. So what can we do to prevent and detect cardiovascular risk early? We can screen earlier and smarter, and we'll talk about what that means. We can measure where fat lives. We can measure blood pressure, and we can do a coronary artery calcium score, or a CAC score. So heart disease in women is often overlooked if we look just at weight or total cholesterol. So we want to look at blood tests like a hemoglobin A1C, which is a 3-month average of blood glucose. We want to look at cholesterol panel, and not just the LDL, but also at the triglycerides and the HDL. We want to look at the other non-HDL cholesterol like apolipoprotein B. We can look at hereditary associated forms of lipoprotein like lipoprotein A, and then look at liver enzymes to clue us into whether MASLD is starting to develop. As far as measuring where fat lives, again, that's about waist circumference. It's proven to be more predictive than BMI. So it's not just about size, it's about the specific location. And then elevated blood pressure accelerates atherosclerosis. So we try to treat early and not just reactively. And then the CAC score. So this is a picture of some calcium inside an artery. What the CAC score does is it picks up and quantifies how much calcium there is. So for women greater than age 40 who have either metabolic risk factors or family history, extensive family history or early family history of heart disease, MASLD, or unclear risk from the labs that we've talked about, a CAC score would make sense. So it detects silent atherosclerosis, and it refines our risk and lets us know when cholesterol is okay, or maybe we need to start prevention, and that includes intensity of prevention. And I'm not just talking about medications, but also lifestyle modifications. So some of the lifestyle modifications we can make, again, this is reiterating some of what we talked about earlier, but is resistance training. This decreases insulin resistance. Sleep restoration decreases inflammation. Protein adequacy is muscle preservation. And visceral fat reduction leads directly to a decrease in heart disease risk. Diet that improves fat profile, usually as it pertains to heart disease, the diet we recommend most is a Mediterranean style diet. I'm not saying that's the only diet, and this is probably a contentious subject, but the Mediterranean style diet focuses more on good fats like nuts and avocados and olive oils, and stays away from saturated fats like butter and red meat. The diet is full of dark green leafy vegetables and optimizing fish and things like that. And then, of course, if you're a smoker, then smoking cessation is one of the best things you can do for your health. So this is lifestyle and modifications that we can make, but then how do medications fit in? There are a few to talk about. There's statins, blood pressure medications, and metabolic medications. So lifestyle builds the foundation, but then medications can help us when risk is high. And we usually consider meds when insulin resistance persists despite lifestyle efforts. Your cardiovascular risk is rising, if there's a strong family history, or if for some reason prevention needs to be done faster or stronger. So statins not only lower cholesterol, but they stabilize plaque and reduce inflammation. Blood pressure medications protect arteries and brain, and metabolic medications like GLP-1s reduce visceral fat and improve insulin sensitivity. And I know GLP-1s are a hot topic right now. It's a little bit outside the scope of our presentation, but they are important medications for metabolic health. And I think it's important to say that medication is not a personal failure. Many times it's just temporary or adjustable. Our goal here is long-term vitality and prevention. Okay, and that brings us to our next major topic, which is cancer. So cancer is the second leading cause of death in the US behind heart disease. There are about 1.7 million new cases of cancer per year. The median age of cancer diagnosis is 66 years old. And in some age groups, like in age 45 to 64, cancer outstrips heart disease, liver disease, and stroke combined. And like heart disease, by the time cancer is diagnosed, it's often been progressing for years. Unlike heart disease, we don't have as many tools at our disposal to detect it early. So really the strategy for addressing the cancer threat is three-pronged. We're going to talk briefly about prevention, detection, and then very briefly mention treatment just as a generality. So for prevention, avoid smoking and other known carcinogens, but then treating obesity is vital. And why is that? It's because excess weight and cancer are linked pretty closely. About 13% of all cancer cases are thought to be attributable to obesity. And obesity doesn't cause cancer directly, but it creates a biological environment where cancer can be, is more likely to grow. Obesity is strongly associated with 13 types of cancer. Type 2 diabetes also increases the risk of some cancers. And then extreme obesity is associated with a 62% greater risk of death from all cancers in women. Obesity, especially with accumulation in visceral fat, helps promote inflammation as dying fat cells secrete an array of inflammatory cytokines. So the same metabolic changes that drive heart disease also shape cancer risk, and the same interventions can help reduce the risk of both. The risk here increases gradually, and risk decreases when metabolic health improves. We do have screenings for cancer that you get. Usually it's talked about at your annual appointment. Cervical cancer screenings begin at age 21 for women, every 3 years, and then at age 30 we go to every 5 years when there's co-testing for HPV that's done. And this is assuming that your pap smears are normal. They'll be done more frequently if you have an abnormal pap. Breast cancer, we usually do screening annually. Some guidelines say every 2 years, but we typically do it annually starting at age 40. And then if you have either dense breast tissue or a previous history of cancer or otherwise increased risk, we do additional screening with either an ultrasound or an MRI. Colon cancer screening starts at age 45 now. It used to be 50. And because of the increase in prevalence in younger people, they've decreased the screening age recommendation down to 45. It's done every 10 years as long as there's no significant abnormality found. More frequently if there are polyps found, or potentially sooner if there's a family history of colon cancer. And then lung screening, if that's appropriate, if you've been a smoker for more than 15 years and it's been within the last 5 years that you've quit. And then just to touch upon treatment, just to show that there are different modalities of treatment. We have immunotherapy, chemotherapy, radiation, and surgery. Okay. But then to kind of bring it back to vitality in general, it's not just, vitality isn't just about how cells age. I'm sorry, it is about how cells age, not just about what diseases appear. So there's factors that increase our cancer risk and accelerate vascular aging, and these also impair brain energy metabolism. These factors are insulin resistance, chronic inflammation, hormonal and metabolic stress, and loss of muscle. So we can see when we start talking about brain energy metabolism, we're getting into the next topic of Alzheimer's and neurodegenerative diseases. And we can see that cancer, heart disease, and Alzheimer's kind of share the same upstream biology. So vitality isn't just about preventing them, it's about preserving these cells. So the same metabolic changes that raise cancer risk don't stop at the heart or the liver. They affect the brain long before memory symptoms occur. So the biology that supports vitality in midlife also protects your brain health later on. This is how we fuel, move, sleep, and recover today, and that shapes how resilient our brains could be in the future. So again, Alzheimer's begins as a brain energy problem. Long before memory loss, the brain is struggling to use the fuel efficiently. And metabolism, insulin resistance, and inflammation all matter to brain health. There are some other hypotheses about what causes Alzheimer's, and the leading one is really the amyloid hypothesis. And that's about this deposition of proteins, amyloid beta, followed by tau later on. There are some genetic mutations that promote very early onset Alzheimer's. And we don't typically, as PCPs or primary care providers, we don't typically do the blood work that you have, this advanced testing that's available for Alzheimer's, but we do refer to neurology and they're able to do them. But we can do early screening. So who might benefit from early screening? Somebody who has a strong family history of Alzheimer's or early dementia. If you have any of the metabolic dysfunction that we've talked about so far, if you have heart disease or high blood pressure, if you have untreated sleep apnea, and subjective cognitive changes that are new or concerning. And what is early screening? What does it look like? It's doing some blood work and checking blood pressure. The blood work, again, is a hemoglobin A1C, a fasting glucose, your cholesterol panel. And then doing a cognitive assessment, such as the MOCA. Some of you might be familiar with this. We have you draw a clock, and there's word recall. There's different visual spatial drawings. And we do this as a baseline. So it's not something that you just do once and done, but you do it over a period of time so we can track changes. And then it's also important to do a sleep assessment. So how can we protect brain vitality? This is starting, you see the same theme again, but strength training, sleep, promoting insulin sensitivity, and vascular health. So for most women, powerful brain protection isn't a specific test, it's how we support metabolism and sleep and muscle and vascular health every day. But screening helps us personalize this conversation. And just to reiterate the strength training, exercise helps maintain glucose homeostasis and it improves the health of our vasculature. But strength training is very important. This study shows that there's an inverse and strong relationship between hand grip strength, which is used as a proxy for overall strength, and dementia risk, or actual cases of dementia. All right, so that kind of covers those four main topics. I did want to touch on just a couple of other ones. Bone health, because we do screen for bone mineral density loss. So this isn't just a fracture test, but bone health reflects long-term metabolic, hormonal, and muscle health. They're all linked. So bone responds to muscle load, Insulin resistance and chronic inflammation can accelerate bone loss, and poor muscle health leads to weaker bone signaling. Menopause is an inflection point because of the estrogen decrease, and that estrogen decrease causes increase in visceral fat. It worsens insulin resistance and it accelerates bone loss. We screen with a DEXA, and that gives us a window into biological aging. So it's not just about bones, it's about resilience. Bone density is another early warning sign when vitality systems are under strain. Just like fatty liver, insulin resistance, and vascular disease, bone loss is silent for a long time. When we do screen for bone density, we're really asking how resilient is this body as we age? Okay, and there are a few tests that I think will probably come up, questions will come up. So to preempt them, maybe we'll talk about. These are tests that we don't routinely screen for in healthy women. And this is cortisol, sex hormone panels, the advanced Alzheimer's biomarkers I mentioned earlier, and broad inflammatory or micronutrient panels. So cortisol, we don't really test for because it's so variable day to day. And if you have an abnormal level, it's usually due to poor sleep or high stress. And it doesn't really change management unless there are red flags present and there's concern for an actual process such as Cushing's disease. Sex hormone panels also fluctuate wildly and widely. Symptoms don't really track with the values. So the clinical context in the situation matters more than numbers. And then the broad inflammatory or micronutrient panels are just very nonspecific. So if something truly concerning is happening, the body usually gives us other clues. And our job as internists is to listen to those clues and then choose tests that actually help us to act. So I just wanted to recap by once again putting up the slide about how to improve insulin sensitivity, because it's kind of what I want to really drill home today, is that it's so important to build and protect muscle, and then to move after meals, to prioritize protein, to fix your sleep if you have any sleep issues, to have a longer fasting window and reduce late night eating, and to lower your stress levels and your cortisol as much as possible. Again, small changes that you can take baby steps and do consistently over time instead of making big extreme swings, I think is more sustainable. And that brings me to the end of the presentation, and we'll take any questions that you may have.
Great. A couple questions.
Okay.
Is intermittent fasting good or bad for a menopausal woman's metabolic health?
Oh, that is a loaded question. There are different schools of thought on that. I think menopausal health would benefit from the longer fasting windows. I don't think we need to be extreme. You don't need to have 18-hour fasting windows, but if we can target that 12-hour fasting window, I think that would be beneficial.
One of the attendees' grandmothers is 87 years old with dementia. Is that cause for the attendee to schedule early testing?
It depends on what age the grandmother first started showing signs and what you would consider early testing. I think it is definitely worth bringing up to the primary care provider and having a conversation about it. And if there's any concern for cognitive change, to do the MoCA test or another neurocognitive assessment, as well as do some of the other lab tests that we talked about. I don't think it's necessarily reason to jump to testing for p-tau, one of the phosphorylated proteins, or to do a genetic screen. But it is reason to do the early screening that we mentioned, I think, with that family history, yes.
Is dementia inevitable for aging adults?
No, definitely not. I think if we focus on the Metabolic health that we just discussed in this presentation, I think that's one way to stave it off. I think there are a lot of factors that we don't understand yet about dementia, but I don't think in any way is it inevitable.
There are many over-the-counter treatments for cortisol. Are they effective?
I would have to know more specifically what they meant by over-the-counter treatments, but no, I think the most effective way to treat cortisol is to get good sleep, lower your stress levels, and do that organically without necessarily supplementing.
Can someone have a low CRP score and still have systemic inflammation?
That's a good question. Usually, I think if you have chronic inflammation, you would have at least a mildly elevated CRP or ESR. They're very sensitive tests. They're not necessarily very specific. It is possible, but I think you would, in general, see an increase in the CRP.
How can I manage my nutritional needs as I age and they change? Is there a resource by age?
Oh, another great question. I value nutritionists and dietitians. I think if we have, or if you have the ability to refer to one of those, that's a great resource. I don't know of any specific age-related resources I can point you to on the internet. And I don't know about your specific insurance if it would cover a referral to a nutritionist, but I think that is a great thing to consider. There's even some great online platforms, not to necessarily promote any specific one, but there are some that take insurance and you can speak with somebody through telehealth. It's very easy and you can get a lot of good information on nutrition.
If someone is struggling with getting enough sleep due to long periods awake during the middle of the night, what are some options to help with this?
It would depend on a lot of factors, age, the reasons that you're awake. I think the first thing to do is to assess for something like sleep apnea. And there's a screening tool we can use for that called Stop Bang. I think as far as addressing the sleep disturbances go, the thing that's been most proven to be helpful and effective is called cognitive behavioral therapy for insomnia. And that really focuses on behavioral patterns around sleeping and having good sleep hygiene.
Are there signs or pains of high cortisol?
Not specifically. If it is high cortisol that is pathologic, like with Cushing's disease, you will start to see signs of it, like with high blood pressure, and there are physical changes that go along with that. If we're talking more low-level cortisol elevation, that's due to stress and lack of sleep. I don't think that there are specific signs of that.
Do older adults still need to go see their primary care annually if they are healthy? My aging parents refuse to go.
They do. We need to do, if you're over the age of 65, we need to do a Medicare annual every year. And maybe a good way to encourage your parents to go is if they want to do testing, that's a great time to do it. Medicare covers a lot of testing. And it's always better to establish care before you need it. That way, when something comes up, you already have a relationship established and that primary care provider knows you. It's oftentimes sad but true, but it's easier to get in once you have an established relationship. So those are reasons I would strongly encourage somebody to maintain an annual relationship with their PCP.
How much vitamin D do you recommend a middle-aged woman take daily?
Well, it depends on your specific needs, how much sun you're getting, what your current vitamin D level is. So that's where I would start if that's the concern, is get your vitamin D level checked. And then we can titrate a dose based on that. Typically, if somebody, our goal is to have a vitamin D level of 30. If it's mildly decreased, I'll start just by recommending 1,000 international units daily. And then as you get more severely depleted, that number will go up.
Is fiber important in your diet for long-term health?
Yes, very much so. Yeah. Sorry, I didn't mention that, but I think fiber is very important.
Are you accepting new patients, and how can I schedule an appointment?
Yes, I am accepting new patients, and you can call Valley View Internal Medicine and they can schedule an appointment for you. I'm usually in Glenwood Springs, but I do go to Willits once a month right now. It's probably going to increase in frequency a little bit, but I'm available in either location.
All right, that is the questions we have.
Okay, great. Well, thank you, everybody. Really appreciate your attendance. Our team would love to hear your feedback on today's presentation. If you have time to fill out a quick survey, it'll appear right after the webinar is ended. And you'll receive an email with the recording of the webinar in the next 24 hours. And the next webinar in the Women's Health Series is Wednesday, February 18th at 12 p.m. with Roaring Forks Family Practices Dr. Haley Hoffman, and she'll be presenting on perimenopause and menopause. All right. Thank you all for joining. Again, have a wonderful afternoon.